So I think this year in lung cancer, at the American Society for the Clinical Oncology meeting in Chicago at the beginning of June, there was a lot of exciting results, but no, there wasn't any one practice-changing randomized phase 3 trial. So sometimes we come away from these big meetings and we go, wow, the results of that trial sets a new standard of care, that changes everything. This was not one of those meetings. That doesn't mean that there wasn't a lot of progress. There was a lot of progress. So a lot of science was reported around understanding how lung cancers that have oncogenic drivers like epidermal growth factor receptor, ALK, ROS1, understanding how those tumors become resistant, what new mutations occur, what new amplifications occur, and how do they become resistant to treatment that they're on. And these sorts of fundamental scientific understandings, and they're really important, will lead us to be able to overcome resistance that these cancers develop. So that when somebody's on a treatment, we're moving very rapidly, be able to analyze cancer as it's changed and come up with a new treatment plan based on those new molecular changes. Okay, so, but that's sort of in the understanding phase of things. So I think that this ASCO, we didn't reach a conclusion so much about, okay, this is the next treatment that we're sure is going to work. We've proven it's going to work. But a lot of important data around EGFR and ALK and ROS and KRAS, understanding how the tumors evolve, how they become resistant, and that is going to lead us to new breakthroughs and how to treat them, how to treat those cancers. I think another important finding in a number of different studies is finding that circulating tumor DNA may be really informative around how people's cancers are responding to therapy, which people are at risk of cancer relapsing. So let me give you an example. So someone might have surgery to take out a lung cancer. And now it may be possible to do a blood test, see if there's DNA from the tumor that persists in the blood. And this may identify patients who are at high risk for relapsing, because it's suggestive that there's tumor left that we don't know about. Or somebody might be on treatment for a cancer. And often now we can do X-rays, we can do CT scans to assess whether the tumor is getting bigger or smaller, is the treatment working? And that's a useful test, but it's not a perfect test, because sometimes the CAT scan underestimates or overestimates how well the treatment is working. So now there's some data that if we look at how much tumor DNA is in the blood, this may be a better reflection of how the cancer is responding to treatment. So data for this looks really solid for being prognostic. In other words, for letting us know which cancers are responding to treatment or which cancers might be at risk for coming back or not at risk for coming back. But it doesn't rise to the level that right away it changes our practice, because we don't know if using this information changes outcomes yet. So for instance, let's say somebody has a tumor taken out by surgery. By standard assessment, we would not be offering them any additional treatment, just based on the size of the tumor and everything else. And we have a blood test that looks at circulating tumor DNA that suggests that there is a significant risk of the cancer coming back. What we don't know at this point is if we do something, we give them some treatment right now, does that make a difference? So what we would need is some sort of a randomized trial where we take these people who still have circulating tumor DNA in their blood, and half of them we give treatment to, half of them we don't, and we see if it makes a difference. Because we're never as smart as we think we are. We may think that some intervention will work, but that the history of medical research is that more often than not we're wrong. And then you can end up exposing people to toxicity of side effects of treatment, of expensive treatment, of wasting their time. It really doesn't work. So I think that the data around the circulating tumor DNA to help us identify which cancers are at risk for coming back, or understanding which patients really respond, where the tumor is responding really well to treatment or not. I think that's really exciting and very hopeful. We're kind of got the next step to do of proving using that information changes outcome. I think a lot of us are enthusiastic that it will. Like I said, we're never as smart as we think we are. And often when we actually test whether or not some intervention is useful, often it isn't. So, so it's only by doing this incremental step-by-step research that we build a foundation that we're certain of, so that we're not building, our treatment house on unsteady ground, where we're making assumptions that a treatment works and we build from there, but it doesn't. It's just incorrect. So I think the data around that is really exciting. I think there's some progress coming along in early stage lung cancer. So there have been a couple of important trials. One was a trial for patients that had surgery for early stage lung cancer, and then were randomized to get standard treatment with chemotherapy, or they were randomized to either get the immune therapy drug atezolizumab or not. And in the tumors that were positive for the immune biomarker PD-L1, there seemed to be a benefit. So that was a study presented a year or two ago that looked good. We had another study from Checkmate 817, where patients who got preoperative chemotherapy with immune therapy, where that seemed to really improve results quite a bit for what we call event-free survival, because basically the likelihood that the cancer will come back. So that was a really positive trial, and I think that'll be practice changing. There were many studies reported at ASCO this year that confirmed these results, that looked at doing more treatment, where patients may have gotten treatment before surgery and then after surgery, or after surgery they received chemotherapy plus the immune therapy at the same time. All of these things look to potentially build on these earlier big studies. The studies that were presented at ASCO this year were very promising phase 2 studies, not big studies, randomized studies that would have us change practice right now. I think really exciting. I think it's an arrow pointing to the future, to how we're going to build on these therapies that we're all already able to offer people. But like, again, not that a big randomized trial where we're confident this changes our standard of care. There are more trials coming along in immune therapy combinations with new targets. So for folks that have been keeping an eye on the lung cancer treatment space, they're all familiar with immune therapies, with pembrolizumab, which is also called Keytruda, nivolumab, which is called Opdivo, atezolizumab, that is called Tecentriq, durvalumab, that's called Imfinzi, cemiplimab, that's called Libtayo. So a whole bunch of them. But there are a bunch of other targets, LAG3, TIGIT, GITR, where the immune system is being blocked at multiple levels. So again, really promising phase 2 results and earlier stage clinical trial results suggesting that we're going to get better results when we do these immune therapy combinations. But the trials were presented while being really exciting for both the science and the preliminary efficacy. They were not big randomized trials that change the standard of care at this time. But those trials are going on. So those trials are going on, and we'll just have to wait and see what the results are. But a lot of promise for the future. And it's that kind of, it's not all home runs, right? So it's not all home runs. Often we make progress in science, as in baseball, by getting a lot of singles and good solid doubles, where we kind of move things along. So I think that pretty well summarizes kind of where we are from ASCO this year. A lot of promising results on the molecular front, a lot of promising results on the immune oncology front, a lot of promising results around being able to test the tumor in the blood to either identify molecular markers that allow us to choose molecular therapy without the necessity of doing a biopsy, either at time of diagnosis, or if somebody's on treatment, when their cancer starts to progress, we can study the tumor by drawing a tube of blood rather than having to stick a needle in them again. And then also, as I was talking about the circulating tumor DNA, to be able to identify which patients are at risk of cancer relapse and or identify which patients are responding or not responding to treatment. So I think a lot of progress and exciting results along all those fronts, but no home run, grand slam trial where just, okay, now everything's different in this particular part of lung cancer treatment, things have completely changed. One of the main oncology groups in the United States is the American Society of Clinical Oncology. And this is a large umbrella organization that encompasses all malignancies. So solid tumor cancers like lung cancer, breast cancer, prostate cancer, and blood cancers. So leukemia, lymphoma, Hodgkin's disease. So it basically covers all cancers. And it is both, so it is a research organization. It is a medical society that brings all of oncology under one big umbrella, and that includes both medical oncologists, surgical oncologists, radiation oncologists, radiologists, pathologists, pretty much everything. They have multiple events, meetings during the year, and that includes the big annual meeting in Chicago. It's for the last 15 years or so, it's been in Chicago the first weekend in June every year. But then they also have different disease-specific meetings. So there'll be like ASCO GI cancer, ASCO GU cancer, ASCO thoracic cancer. So they have some, they'll subspecialize and also look at palliative care, supportive care, other types of more specialized meetings. They publish a number of important journals, the most important of which is the Journal of Clinical Oncology, which is one of our premier oncology journals. So American Society of Clinical Oncology meetings are certainly one of the meetings around the world that people will look to present their results from the biggest, most important clinical trials and scientific breakthroughs. So typically, typically in Chicago, big annual meeting would draw somewhere between 35, 40,000 people. So it's really quite a meeting. beyond beyond just the presentation of the data and the abstracts and the talks, a lot of the business of oncology gets done there, where people meet, talk about what trials ought to be done, brainstorm and decide what clinical trials should go forward. Like if I was going to propose a clinical trial that we would do at Duke, and I wanted a company to sponsor it, that's where it's all the leaders from these sponsors would be at the meeting. I would eventually try to get some time where I could get 2 or 3 leaders together and make a pitch. So like everybody's going to be there. So it's potentially an opportunity to get people together and make some proposal about some new line of research, try to get it supported and funded, and drug supplies and everything else. So it's really integral. It's singular within the United States. Certainly it's singular within our oncology calendar, where most everybody goes to it, both to hear the new information that's coming out, but also make connections, and then be able to network and get business done. I think that I'm really hopeful because we have made so much fundamental progress in early stage cancer, both with post-operative immune therapy and molecular therapy, pre-operative combination chemotherapy plus immune therapy. We're really going to be able to cure more people with early stage disease. And this is, of course, in conjunction with being able to screen for lung cancer in people that are at high risk. So I think that our ability to identify patients with earlier stage disease and then give them treatment that will maximize their chances for cure has really come together in the last 5 or 6 years. So that's really exciting. Be able to improve our cure rate for lung cancer, really important. In stage 3 cancer, where non-small cell lung cancer, where the cancer has not spread out the body, we can't take it out by surgery for various reasons. About 5 or 6 years ago, we had the results of a absolutely practice-changing trial called the Pacific trial, as in Pacific Ocean, where patients receive standard radiation and chemotherapy, and then either receive no additional treatment, which was standard, or the immune therapy drug durvalumab. And now we have 5-year follow-up showing that clearly the addition of the immune therapy improves the long-term survival and cure rate of this treatment. And that trial was led by our own Scott Antonia. So that has been an absolute practice-changing trial that changed everything. Advanced disease, now we're able to identify more patients every so often. Every year or two, we're adding some new molecular target that we have some sort of effective oral therapy for. Of course, there's EGFR and ALK and ROS1, BRAF, MET, RET, and most recently, we've made progress in treating KRAS. So KRAS is the most common oncogenic driver that we know about in lung cancer, non-small cell lung cancer. And for years, it was just a tough nut to crack. We just could not find an oral therapy that was available and effective. But now for the most common KRAS variant, which is KRAS G12C, there are a couple of effective oral therapies that can get good responses in many patients that are pretty durable. So that continued breakthroughs in being able to diagnose and treat people have things to offer. And then in the immune therapy space, we have immune therapy combinations for people with immunologically hot tumors, all the way down to immunologically cold tumors. And for these patients that don't have the oncogenic driver, where we can't offer them oral therapy, even in all of those patients, we have a meaningful chance of getting a 5-year survival, which 15 or 20, when LCI started, we really couldn't talk about that. But now we can. So even if we can't promise people, and even though we're not doing as well as we need to do, pretty much any patient who presents with lung cancer now has the realistic hope of living 5 years and doing well. That's a sea change from when LCI started. So yeah, so I think that, we've had progress all through the spectrum of lung cancer, including improvement in small cell lung cancer. It's a cancer that I do a lot of research in, where there have been some improvements over the last 5 or 10 years, where we've added in immune therapy, and we're getting some long-term responders in small cell lung cancer. So I think throughout the spectrum of lung cancer, improvements for every stage of disease, every type of disease, and I think that is just going to continue.